We're going to have my co-director, Dr. Daphne Holt, speak about something that she has gotten really, since I've known you, more and more interested in. I alluded to this, which is prevention, and not just a type of tertiary prevention that I talked about, preventing another hospitalization once you have the illness, but perhaps, you know, trying to identify people much, much earlier. And I'm curious to see what you have to say. Each year, you're making tremendous progress, I have to say. So, thank you.
Thank you. Yeah, so I think this topic of prevention, early detection, I think is a good one for a day where we're talking about community psychiatry in particular. Because I think the main sort of gist of my talk really is that the best place to do early detection prevention work is in the community. But this is only beginning to happen, actually. And so I'll tell you a little bit more about that. I'm going to be talking a lot about projects that we're doing here at MGH, just as examples of these sorts of efforts. But some of these projects are kind of in the early stages. So I'm just going to give you kind of a little bit of a sweeping overview of some of this kind of work, and then just realize that there are lots of other people out there in the country and in the world who are also doing some things, some really innovative things in this area. And you know, I try to keep my talk a little bit short, just because I think that being here is such a great opportunity to have a conversation, so I'm really interested in having something of a discussion here. Because I think, you know, you all will have some thoughts about this, I'm sure, and I would love to hear your thoughts. So I just wanted to pose a couple of questions before I talk to kind of stimulate some thoughts. So, you know, the question is, you know, if it was possible, do you think it would have made a difference to you or your loved one with schizophrenia or a related illness to have received some sort of help or information or something like that, you know, monitoring, accommodations, treatment, earlier than what did happen? And then, you know, this may or may not be the case for you. You know, it's certainly, everybody's different, and everybody's situation, you know, has a different kind of story, a different trajectory. But if your answer happens to be yes to that question, knowing what you know right now, do you have any ideas, basically, is my question. You know, how or where or from whom could you or your loved one have received some sort of intervention? And based on your experience, you know, what would you recommend? Do you have any thoughts about that? Now, I think sometimes when we talk about prevention, you know, when we've already been affected by the illness or our family members have been, it can feel a little bit painful because it's, you know, it's sometimes a sense that there's a sense of regret. I mean, I know I have people with lived experience in my family. You know, the sense that you could have done something different, that you should have known something that you didn't know, you should have noticed something. And so I don't want that to be a big part of, you know, your experience today, because I really want to emphasize that in this, the way that our system is designed at the moment, our mental health system of care, we really do not have any great ways to detect the illness early or to prevent the illness, unfortunately. I mean, that's sort of the negative side of what I'm going to talk about. But, you know, we're just at the beginning of this journey. So unlike many other areas of medicine, almost all other areas of medicine, to be honest, where there have been huge advances, you know, in the areas of early detection and prevention, you know, in cancer detection, cardiovascular disease, you know, infections. I mean, we have all these great vaccines. You know, these preventative interventions have transformed medicine in the last 50 to 100 years, right? But for whatever reason, this kind of movement towards early detection and prevention has only just begun in psychiatry. So we really don't have a way to do this, and so it's nobody's fault that, you know, if we are not able to prevent these illnesses right now. We can't do it that well right now. But we want to catch up with the rest of medicine, and, you know, we can speculate a little bit about why we haven't made that much effort to prevent these things. I think stigma actually plays a huge role in the fact that we haven't gotten the resources to work on prevention as much as other fields of medicine. But I think those things are changing, and there's some really interesting new initiatives. You know, most importantly, obviously, the movement across the country to provide very sort of intensive care for the first episode of psychosis. You know, coordinated specialty care, which has really improved the care of people when they're first experiencing a psychotic episode. But we do need to move the dial earlier, and there are some efforts to do that as well, mostly in other countries, but they are coming here too. So as Dr. Freudenreich mentioned, we do know a lot more about the biology of serious mental illness and schizophrenia in particular. And we know for sure that it is an interplay, the causes are sort of, you know, an interplay between genetics, you know, genetic susceptibility, which probably accounts for maybe 50% of the risk, something like that, for psychosis and psychotic illnesses. But there are also really important environmental effects, you know, that have been very well established at this point. We know that things that happen in utero during pregnancy have a role, but also there are later things that happen. Childhood adversity definitely has an effect. You know, cannabis use is now turning out to be a clear contributor to the cause of schizophrenia. And interestingly, you know, being a minority and the social stress that accompanies being a minority, particularly if you experience some discrimination, contributes to the risk for schizophrenia. And interestingly, living in an urban environment. So all of these things have to do with stress, all these environmental factors. Stress on the brain, stress on the person's sense of self, you know. And these are things, you know, the good news is these are things that, you know, we might be able to modify. Either the negative sort of environmental event itself, or we can sort of help people in terms of how they recover from that experience, or how they might, you know, become more resilient in the face of that experience. So the fact that we now know that the environment plays a very big role in the etiology of these illnesses is really good news for prevention. So, you know, one big question in this field is, when should we intervene? You know, and as, you know, Dr. Freudenreich was talking about earlier, I think it's really clear that we want to, you know, do preventative sorts of work at all stages of illness, including before the illness, but also, you know, to prevent further disability and relapse and that kind of thing later in the course of the illness. But one big question has been, I guess there's no light here, right? No. Is, you know, whether how early can we intervene? And a lot of the work that has been done in the area of trying to prevent schizophrenia has focused on this period that was right before the onset of the illness, that you can see this like bump in this graph here, the orange bump that says APS, which stands for attenuated psychotic symptoms. So a large percentage of people who develop schizophrenia have this period before the illness, which we call the prodrome. And the prodrome is like a general term that people use for the sort of the prelude to any illness. You know, if you have an infectious illness, you often have a prodrome, right? When you start to have the flu or something, you start to feel achy a few days beforehand. So a lot of people develop these kind of mild symptoms that in about a third of people who have kind of classical prodromal symptoms, they will go on to develop true kind of clinical psychotic illness, like something like schizophrenia. So a lot of the research on prevention has focused on this period, and I'm going to mention some of that briefly, but there has been a big movement now to also try and identify people even earlier, even when they have almost no symptoms or very mild symptoms that are kind of non-specific. And when we focus on that earlier stage, we're really not talking about necessarily trying to prevent schizophrenia specifically. We're really thinking more, kind of transdiagnostically is the term, trying to prevent serious mental illness of a variety of types. So the other big question when we're thinking about early intervention and prevention is, where should we do this? And this is where this kind of idea of working really in the community where people are comes from, because a lot of the work that's been done so far has really focused on people who are already seeking help, treatment or seeking help. People are already kind of having some pretty significant illnesses, significant symptoms, like when they're in the prodromal phase, where they're already sort of experiencing some deterioration functionally. Maybe people's grades are going down, or they're not able to work, or they're really having some significant depression or anxiety. So they're going to a mental health clinic. But what I'll argue a little bit later is that perhaps we really need to move beyond the mental health system and really do this kind of work where people are in their neighborhoods, schools, and doctors' offices. So this slide just kind of summarizes just a huge amount of work that's been done in this area, where people have studied various different kinds of treatments. A lot of it has been psychosocial treatments like cognitive behavioral therapy. There have been some studies that have used low doses of antipsychotic medications. Some have used things like fish oil. And some of this work was really exciting and promising in the beginning, in that people have showed some effects. So giving one of these treatments to somebody in the prodromal phase, experiencing some attenuated sort of low-level psychotic symptoms, but not true full-blown sort of illness. But I don't know if you can actually read this. I wish I could point out that if you look in the outcome section, so these are kind of lists of various studies that have been done over the years, and the outcomes, so it will say in the top, we found there were some significant differences between the treatment group and the group that didn't. Oh, yeah, right there. Thank you. People, like for this study here, this was essentially the first study. It was done in Australia, that there were significant differences at first, but then later they didn't find a difference. Similarly, this study used CBT. Initially, at 1 year after the treatment, they found differences, but then when they looked at these people later on, there were no differences between the groups, and sort of on and on. The only one here that doesn't say no significant differences is this one where they used fish oil. But more recently, this was published in 2012, this review. More recently, that study was repeated, and they did not find a difference. So sadly, this whole effort has really led people to conclude that treatments in this prodromal phase may delay the onset of psychosis in some people, but it doesn't seem to prevent it. And there are probably other reasons for these negative findings. The other one being that some people in the prodromal phase just recover, spontaneously. That this prodromal period doesn't always mean that people are going to develop psychosis. So it means that we also need better methods for identifying who is truly at risk for these illnesses. But one thing that that I think people are now beginning to try, as I mentioned, is this idea that maybe we can actually find people out there when they're not experiencing distress, maybe just sort of mild forms of symptoms or other kinds of risk factors, and do something there, and maybe find some ways to reduce the risk of serious mental illness at an earlier stage. So I'm just going to give you a couple of examples from our groups here at Mass General, some work that we're doing in this area. This is kind of, I think, kind of an obvious thing to do in some ways, in that, we all sort of know from the literature, or many of us have become aware that the peak age of onset of schizophrenia is in late adolescence, early adulthood, and the age overlaps with when many people are in college. Yet, for some reason, there are really no validated screenings in colleges, mental health screenings, particularly for symptoms of serious mental illness. And in high school as well, there's really little that is done in that respect that's kind of been validated using sort of empirical data. So we have been doing some work along these lines. And so one big issue, though, with this kind of work, as I've mentioned, is that how do you know, how can you figure out who might be at greater risk for serious mental illness at this earlier stage where people are not necessarily very symptomatic? And, a lot of work is being done to ultimately find some way to have like a biological test or a tool or, a scan or something like that that can really help us figure out who we need to pay attention to and help. And, I think obviously that would be incredibly helpful in the end. But the reality is we actually do have some tools that have been around for a long time that we can use now that are actually not too bad. We have these very basic questionnaires where we can assess whether people have what we call sort of subclinical psychotic symptoms or psychotic-like symptoms, psychotic-like experiences. There are lots of different terms for these kinds of symptoms. And it turns out these symptoms are very common. At least 7% of people have these kinds of mild symptoms. And maybe more, it depends on how you define them. It could be 30% of people have these kinds of symptoms. And so for many years, people have studied these, but they've thought, oh, they're not really important. It's sort of like just like a false positive. It has nothing to do with real psychosis, and we're not going to pay attention to them. But in recent years, people have found, and I'll just give you all of this, it's a lot of words, but I'll just kind of summarize that there's a fair amount of evidence that these symptoms actually are related to what we consider to be, true kind of clinical psychosis, the things that we would worry about. There are a lot of similarities between these symptoms and clinical psychosis, including that mild delusional beliefs and sort of very low-level hallucinatory experiences, which many, many people have. They cluster together in people, so people who have mild sort of, a few sort of unusual beliefs, let's say, and perceptual abnormalities as people are the same people. And then we know that these symptoms are heritable, kind of in the same way, so you can inherit them. If your family member has them, you're more likely to have them. So it's similar to what we see in schizophrenia. And we do know that even though these are very common, so having one of these symptoms does not increase your risk for schizophrenia, really. But if they're persistent and they're also somewhat distressing, people have found that they actually do increase your risk for psychosis, about tenfold, which is about what your risk is if you have a first-degree relative with a psychotic illness. So it's comparable to genetic risk. So that's a pretty significant amount of risk. And then one of the other pieces of evidence that's really interesting, I think, that these symptoms are similar to schizophrenia in some way or related biologically to schizophrenia is that all the same environmental factors that increase your risk for schizophrenia also increase your risk for these symptoms. And there have been neuroimaging studies that have shown that some of the changes in the brain that you see in schizophrenia, you also see in people with these symptoms. So there's lots of kind of indirect and direct evidence that there's kind of a continuum between these mild symptoms that are mostly benign, but occasionally when they're more persistent, they're more concerning and maybe are more related to psychosis. And that there's a continuum between these and more clinical, more severe forms of these symptoms. And one thing that we have been very interested in is that there's a lot of evidence that these symptoms are related to what's called stress sensitization. And the way I think about it is that the parts of your brain or your mind that are involved in kind of calming yourself down when you're dealing with stress, it's called emotion regulation, you know, the way that you kind of can manage emotions in difficult situations, that those mechanisms are more sensitive in people with these symptoms. And it's a little bit harder to regulate emotions when you have these symptoms, or if you're someone who's susceptible to these symptoms. And we have been studying these symptoms in college students and in other populations, and we have found, just like a lot of other people have found, that these mild kind of delusional beliefs, like worrying that, you know, somebody might be watching you, or feeling, you know, that people aren't really what they seem exactly, you know, just very mild things that everybody thinks sometimes, but some of these, you know, some people think a little bit more often, that they correlate very strongly with also having some perceptual abnormalities, like maybe hearing your name or something along those lines. And then we've also found that emotion reactivity, which is this kind of difficulty with emotion regulation, correlates strongly with these symptoms. So our group has developed this 4-session workshop, which we call resilience training, for people with these mild symptoms. You know, Dr. Caregiver and some other people in our group have used sort of basic CBT methods, but added these more recent modalities, you know, mindfulness, self-compassion, and mentalization. So the idea is to train people in skills that make it easier to regulate emotions, and also to be more self-aware and more aware of other people, to sort of improve social functioning, which also improves resilience. So we've been screening college students for the last 2 or 3 years now for these symptoms, and conducted 190 workshops. We've done 20-something workshops with 190 participants, and we've been studying, you know, whether these workshops actually affect these symptoms, and we have found, indeed, like in this kind of very simple study where everybody did the workshop, we found that symptoms were reduced. These psychotic experiences were reduced, but also depression, anxiety, and we saw increases in what we call resilience factors. And then we did another version of this study where we actually had a control group that didn't receive the intervention. And you can see here that the people who received the workshop, who did the workshop, had a reduction in depression, the psychotic experiences, and also distress related to the symptoms. All the people who were on the wait list who received the workshop later didn't experience any of those symptom reductions. And then we also saw increases in self-compassion and what we call positive affect, so the experience of pleasure and joy in life, which has really been shown to be a really important factor in people's psychology in terms of promoting resilience and protection from stress. So, and what was interesting was this increase in positive affect actually correlated with all the reductions in symptoms. So it seems like what we're doing in this workshop is helping people, you know, manage negative affect, feel more pleasure, and that this actually leads to some symptom reduction. So obviously the goal ultimately is to see if this kind of intervention might have some long-term effects on how people do. And so we're measuring that over the next few years. We'll see if people who you know, participated in the workshop are less likely to need psychiatric treatment, and you know, we're measuring other things having to do with outcomes in terms of college retention and things like that. And then we're also, you know, you probably know that I'm interested I do brain imaging, and I'm interested ultimately in identifying markers of these illnesses, markers of risk for serious mental illness. And so we're also looking at these pathways in the brain that we think are involved in emotion regulation to see if we're actually improving their functioning with this intervention. So I know I don't have a lot of time left, so I'm just going to talk very quickly about some related projects. So we're going to do something very similar in middle schools in Boston. We're collaborating with Randy Schuster, who's in the Center of Center of Addiction Medicine at Mass General, and also, of course, with Corey Cather, to do something similar, but it's with a longer intervention that we've developed, and it also has a parent component. So parents come to 3 sessions of this workshop and learn about all the skills that we're teaching their kids so that they can help support that learning at home and also learn some of those skills themselves. So we actually have been piloting this in this workshop, this whole intervention, in another study, and this just brings me to the kind of the third idea of where we could start doing more preventative work. In this study, which is conducted in the Chelsea Health Center, we actually screen kids when they visit their pediatrician for their annual visit to their pediatrician. And so this is the same age group as in the previous study I just showed you, this middle school age group. But we're screening people, kids in this, with a very general screening tool that really looks at all symptoms of potentially that would increase risk for mental illness. And we've seen some promising effects on these kind of low-level symptoms. And we also have the parent caregiver sessions in this. This is where we actually developed this intervention. And this parent caregiver piece to this intervention has been very well received, and we really feel like this is an important component that we would like to expand on in the future, because obviously with kids it's really important to get the parents involved. But you can see, I won't read you all of these, but some of these parents really felt like this intervention had an impact on their relationship with their child and how to help their child experience their emotions. So they helped me understand the emotions of my child. We don't talk a lot. Everyone is always in their own world, and I learned how to share with her. Let's see, this parent said, I learned how to talk to my son so he can tell me exactly how he was feeling and why. So you can see this gives you a little bit of a flavor of what's focused on in the workshops. And then the last strategy that's kind of a new, exciting thing that people are very interested in right now. This is a way to screen lots and lots of people and not really use any particular hypotheses. We're really, in this method, we're using this technique called machine learning, which is, kind of a way of just crunching lots and lots of data and figuring out, without having any preconceptions, what might predict a psychotic episode. So in this study, which is led by Jordan Smaller here at Mass General, they're going to use the entire electronic medical records. So basically, if anyone has visited their doctor and then later develops a psychotic episode, this study will look at what in all these tiny little pieces of data that we can collect in the electronic medical record, what might predict that happened to that person. And then you can use that information to then look at people who might be at risk, try and identify with this algorithm that's just generated from all these data. We can develop a tool that will then sort of pick out, okay, maybe this person, even though they just seem a little bit depressed or anxious or something, maybe they could use a little bit more monitoring or an extra evaluation of some kind. So this is really exciting new work. There's some other people, there are people in Europe who are doing some similar kinds of things. So I think this is my last slide. So I'll just summarize by saying, it's sort of been a long time coming that finally the world of public health and the powers that be at the NIH and in other areas of the government have decided that developing, methods for early detection and prevention of mental, serious mental illnesses of all types, not just psychosis, is a major public health priority. And as I mentioned, this has been a very successful area, domain of medicine in all other fields of medicine. And so it clearly makes sense for us to put resources and efforts into doing this in psychiatry, and particularly for serious mental illnesses. So as I mentioned in the beginning, unfortunately, some of the first efforts to do this, although, it's not, this strategy these people tried with the prodromal participants is not, people are still adjusting it. So I don't want to say that it was a complete failure, or if the jury is, the jury's still out on that work. But so far, that strategy of trying to identify people who are really at what they call ultra high risk, who are almost, clinically psychotic, but not quite meeting that criteria. That strategy has not so far panned out yet. So what I'm trying to convince you, and hopefully give you some evidence that strategies that are implemented in community settings where people are, where they're going, either to school or the doctor's office or the pediatrician, that are really identifying people who are not necessarily upset or distressed or all that worried about what's going on, but maybe have some small sort of concern, and that are more transdiagnostic, meaning, at that early stage, we can't say whether somebody's at risk for schizophrenia or bipolar disorder or depression. So that those are really some amazing, very exciting, new approaches that I'm hoping we'll hear more about, and I'll report back to you in subsequent years about. And I just want to emphasize also that it's likely that a number of different approaches, all of these approaches, that I've mentioned, are going to be useful and necessary given the complexity of serious mental illness and the multiple different causes. As you remember, that first slide I showed you with the genetics and environment interacting and all the different kinds of environmental effects that we need to think about, given the complexity and the diversity of the people that we're trying to help. I think all of these approaches are going to be necessary to investigate at least and to consider. So I think that I'll conclude with that, and let's see, I have one more slide just to acknowledge all the people who have worked on the projects that I mentioned to you. We have this program called the Resilience Program, and also my lab, have really contributed to these things, these early projects, and then these funding sources like the Sidney Bear Foundation, and of course the Center of Excellence for Psychosocial and Systemic Research, which you'll be hearing more about later. So thanks for listening.